Today we are here for the orthopedic medical session, and we have with us Dr. Ravikant Bhutseti, and who is a MS Orthopedics. And the topic which we are going to discuss here is the open fracture, which is an emergency, as you know. Yeah, over to you, sir.
Hi, myself Dr. Ravikant Bokshetty. I've recently completed my MS Orthopedics in BLD Bijapur. So today we'll be talking regarding open fractures. So open fractures, as we all know, that it is an emergency condition in orthopedics, where there is a fracture. Along with that, there is a skin and the subcutaneous tissue, and the soft tissue is also damaged, which is directly communicating with the fracture hematoma and the fracture site. So thus causing contamination of the wound and infection of the bone. So it is also called as compound fractures or open fractures. So there are three important things that we need to focus in this. There is the contamination of the wound, which is very important to rule out or for the prognosis of the infection or the osteomyelitis. Then there is crushing, stripping, or there is damage to the periosteum, and there is damage to the soft tissue coverage, which covers the bone. Okay, so as we all know, tibia, one surface of the tibia is subcutaneous. So that surface of the tibia has higher chances of causing open fractures if there is fractures, if there is a fracture of the tibia. So that surface of the that surface of the skin gets broken easily as the bone is subcutaneous and can get easily infected also. Then coming to the exact mechanism of injury, why this occurs. So open fractures occur more commonly because of the high velocity of injuries and not because of slow velocity of injuries. High velocity injuries like road traffic accidents, but in these conditions there can be polytrauma also. Then there can be it can be because of a fall from a very a height, like very too much height. So the patient can get easily fractured, and also because of the road traffic accidents and because of sports injuries also. But sports injuries also violent sports injuries, not because of any minimal injuries. Less likely because of minimal injuries. Okay. Then coming to how will you evaluate the patient of open fractures when the patient comes to the casualty. So once any patient comes to the casualty, the general protocol of ABCDE is to be followed. That is airway, breathing, circulation, disability, and exposure. We all know what airway, breathing, circulation is. It is already discussed in the emergency medicine lecture. So here in our condition, important is disability. Disability means how is the patient coming to you? Is the patient coming to you walking, or is the patient coming on a wheelchair? Is the patient conscious or unconscious? In what condition the patient is brought to the casualty? That is important. Is the patient able to walk, not able to walk? Then the exposure. Exposure is basically the patient's clothing. If the patient is wearing a belt, if the patient is wearing a band around him, which is hampering the blood supply to the distal part of the limb, distal pulse is not palpable. So in such conditions, the clothing is very important, and hence the exposure of the patient, complete removal of all the clothes on the body is very necessary in traumatic conditions. In most commonly in polytrauma cases, where we do not know the exact sites of the injuries. It can be multiple injuries. Then another after all this once the patient is stabilized, like for example the patient's IV line is secured, patient's pulse BP is maintained, we need to rule out the other serious injuries, that is head injury, chest injury, abdomen injury, pelvis injuries, and the spine injuries, which are very important to rule out in a polytrauma case. So these factors are evaluated. Further moving on, we once the patient is stabilized, once we rule out there is no major injury, then we come to the open wound or the open fracture or open injury, or if there is any injury. So how do we know if it is an open fracture or if it is just a wound? We just by clinically we cannot say if it is open wound or open injury, because any patient, if it comes in the casualty with a wound and the patient is unable to walk, we consider that as an open fracture. Okay, so in most of the cases the wound might be connecting to the fracture site, but we cannot rule out clinically. We need to have an x-ray. We need to intraoperatively we can evaluate during debridement. Okay, then important thing is neurovascular status of the patient. distal neurovascular status is very important in open injuries because there are higher chances that there will be neurovascular injuries in open fractures. Like for example, if there is a distal radius fracture, there is higher chance that there is injury to the radial artery. Okay.
Yes.
Or there can be a nerve injury if there is a humerus shaft fracture, like there is a mid shaft fracture, radial nerve can get damaged. So these things need to be evaluated. So this vascular injury can be evaluated by measuring the ankle brachial index. There is a thing called ankle brachial index, which measures the systolic blood pressure in the lower limb is to systolic blood pressure in the upper limb.
Okay.
So this ratio should be more than 0.9 normally. If this ratio goes less than 0.9, then you suspect that there is a lower limb vascular injury. So this is how you can rule out, and immediately you can consult a vascular surgeon immediately. Okay, for the further evaluation. Then moving on, there was one question that if there is open fracture, can there be a compartment syndrome? No, there cannot be compartment syndrome when there is an open fracture. That's what compartment syndrome means. Compartment syndrome means there is the pressure inside a closed compartment is increased. So we all know that each limb, for example, upper limb or lower limb, everything is divided into multiple compartments, which is supplied by a particular nerve and a particular blood vessel. And it has those particular muscles in that particular compartment itself, which is enclosed by a intercompartmental fascia. Okay. So this fascia, the pressure inside this fascia increases. What happens in the open fractures is there is directly opening up of the compartment. So you don't really have any increased pressure inside the compartment. But what happens in compartment syndrome is the pressure remains inside, the pressure goes on increasing. For example, if there is just a blunt trauma, or there is just a fall from the height, the patient will say that there is pain, tenderness and all, he will complain. But there won't be any external wound, or there won't be any significant soft tissue injury which is visible. So,
But the other compartments
in such
can have compartment syndrome also. Other compartments of that area.
Other compartments can have compartment syndrome.
Because of trauma.
Yes. Other compartments can have compartment syndrome, but that is also very less likely. That is very less likely. Okay. So whenever there is an open wound, there are more chances of there are less chances of compartment syndrome. Okay. So yeah. So compartment syndrome also, there are these 5 very important points which we see. There is 5 P's we consider. So this is a mnemonic that is 5P, where you see pallor of the skin. There is pulselessness. There is paresthesia. Then there is paralysis, and also there is pain. So this pain is out of proportion. Okay, and this is not just simple pain like a normal trauma. This pain is out of proportion, and there is stretch pain, which is very characteristic of compartment syndrome. To consider this. Okay, so. Also, compartment syndrome can be diagnosed like this by 5 Ps in the adults, but in the children you cannot exactly say if there is a stretch pain or what type of pain it is. So what do you do in children? There is 3 A's. Okay, this is a mnemonic that is 3A in children, that is followed. That is increased use of analgesics. So if the patient is requiring excessive use of analgesics in the children, then there is pain out of proportion. Again, the patient is aggressive because of that. Okay, patient is agitated because of that. So that is one thing. And hello. Yes. So there is a patient is agitated, increased use of analgesia, and also the patient is aggressive. So these are the factors that you can come to the diagnosis of compartment syndrome in the children also, which is more commonly seen in supracondylar humerus fractures of the upper limb in the children. Okay. So now coming to the radiographic evaluation, once you are done with evaluating the patient and stabilizing the patient, only then the patient is to be shifted to the X-ray room or to get the investigations done. Till then, the patient is not to be shifted. If the patient is unstable, patient is not to be shifted. So whenever we are doing the radiographic evaluation, we get the X-ray of the involved limb. For example, if we are suspecting there is a wound
there is a wound over the tibia. Okay, so we get the X-ray of we don't just get the X-ray of the tibia, we get the X-ray of the knee joint also, we get the X-ray of the ankle joint also. Okay, so most of the times what happens whenever there is these are, as I said, these are high energy violent injuries. So these injuries, when they occur, they can cause ligamentous injuries also in one of the joints above or below. So you need to, or they can cause some avulsion fractures, or they can cause some the fracture line might extend till the joints also because of the high intensity of the wound, high intensity of the high energy of the wound. Wound. Then these are the X-rays. Also, we can get one CT scan done if the patient is extremely stable and the patient is like we can get the CT scan done, nothing like it. If we get the CT scan done, we are clear about the type of the injury, type of the wound, and the type of the fracture also. Also, we can rule out the most important thing to get CT done is if the joint is open. For example, whenever there is fractures occur, the road traffic accidents, the knee joint, there is a CLW over the knee joint. So we do not know if this continuous lacerated wound is directly communicating with the knee joint or it is just superficial to the knee joint. So how do you rule this out? You get one CT done. If there is air inside the joint, then you consider that this is arthrotomy has happened. That is a traumatic arthrotomy has happened in this. Okay. So whenever a patient with open fracture comes, so it is classified according to Castillo-Anderson's classification. This Castillo-Anderson classification is routinely used in all the trauma centers throughout the world. So it has three types in it: type 1, 2, and 3. And further, the type third is divided into A, B, and C. Okay. So I will just tell the gist of it, how it is classified. It is classified on the basis of the size of the wound. Okay. Type A wounds are less than 1 centimeters. Type B wounds are 1 to 10 centimeter wounds, and type C wounds are more than 10 centimeter wounds. Okay. Then the level of the contamination of the wound. So type A wounds are mildly, type 1 wounds are mildly contaminated, type 2 moderately contaminated, type 3 severely contaminated. Then then there is another on the basis of the soft tissue injuries. Okay, so type 1 and 2, the soft tissue injury is minimal, whereas in type 3, the soft tissue injury is maximum. There is a crushing of the compartments can occur in this condition. Okay, so what exactly means crushing of the compartments? That all the muscles, all the nerves and the blood vessels in that compartment is completely damaged in this condition. Okay, so that is one. And there is also a condition where sometimes all the muscles and all the structures are intact, but the overlying skin gets damaged so much that you cannot directly approximate the skin, so that gets damaged. Okay, so that is one thing. Then there is vascular injury, most important. This vascular injury can also be classified in the Castillo-Anderson classification, where if there is a vascular injury, immediately the vascular surgeon needs to be approached and the vascular repair has to be done. Okay. So how do we know if there is if there is a vascular? I'll come back to that again. But before that, there is a type of the fracture. In type 1 injuries, the type of the fracture will be simple fracture, type 1 and type 2, or minimally comminuted fractures. But type 3 fractures, there will be severely comminuted and the bone loss will be there. Okay. So sometimes so much comminution will be there that the bone loss will happen. Okay. Also, what was I coming to the vascular injury? So whenever there is a wound, okay, you do not directly run towards opening the wound whenever the patient comes to the emergency department. As I said, you stabilize the patient completely, and then only you come to the wound part, because the wound is not that important. Because if the wound is proper dressing is to be done, the patient might have gone somewhere. Okay, there is a clot formation already. So you opening the wound and again dislodging the clot and again it causing the bleeding, that can cause much trauma to the patient. So you better stabilize the patient first. Once the patient is stabilized, then you open the wound. If the dressing is done already, you open the wound layer by layer. Once the wound is opened layer by layer, sometimes there is a collection of the blood. Okay, this blood will be dark in color. That is a fracture hematoma. Okay, this dark hematoma, you need to rule it out from fresh blood. Okay, so fresh bleeding from a damaged vessel is warm. It is fresh, red in color, and it will be continuous. Even if you whatever methods you apply to stop the bleeding will be continuous. Okay, But whereas if there is a fracture hematoma, it will be dark red in color. It will be brownish in color. It will be warm. It will be comparatively less warmer than the fresh blood,
Yes, sir.
and also it will stop on its own. You don't have to do anything. Okay. Okay. So this is the fresh bleeding, and this is the fracture hematoma. So fracture hematoma, once you open the wound and it is bleeding, there is no need to get panicked. I've seen so many people who get panicked looking at the blood itself because it is continuous bleeding. Once it is continuously bleeding, just put direct pressure on the wound. Once direct pressure on the wound is applied, the bleeding stops on its own. Whatever it is, if it is a vascular injury also, and if it is a fracture hematoma also, the bleeding stops on its own. Once the bleeding, you check it again after a few minutes. If the bleeding is stopped completely, you try to just visually explore the wound. You do not manipulate the fracture site too much. You do not remove the bony fragments which are already too much visible, or you only remove whatever foreign body is stuck. For example, a stone is stuck there. And it is easily visible. You remove that stone easily. Okay. So this is to be done. So yeah. So there was one more question that yeah. So there was one more question that whenever there is open fracture, when is the patient to be operated?
Yeah.
So the patient is to be operated exactly. So the patient is to be operated within 24 hours, not more than 24 hours. Okay. But this whole thing depends upon the patient's general condition. Like the patient's general condition. If the patient is stable, if the patient's vitals are stable, then the patient can be operated immediately. Okay. Or if the patient's general condition, patient has a head injury, patient has a chest injury, and the patient, it is life-threatening for the patient, then you do not operate this part first. You get the patient stabilized first, and then you can operate this part. Okay. So these are the parts of the priorities when you operate. Also, as early as if operated within 6 to 8 hours of the injury, there are less chances of infection. Almost 90% less chances of infection will be there. So if the patient is operated within 6 to 8 hours, there is less than 90% chances of there is 90% improvement will be there. No chances of infection. And also after 24 hours, there are very high chances of infection. The patient can go into sepsis also. Okay. So however small the wound may be, okay, open fractures means the bone has broken out and it has come out from the skin. So that means that it has caused taken some infection inside. Okay. So there are higher chances that the bone can get infected. And once the bone gets infected, there is no any dreaded complication as osteomyelitis as this. So it is very important to debride it thoroughly when we are taking the patient for the operation. What do we do during this surgery? We do debridement. Okay, so debridement is done. Whatever foreign particles we see right from the skin, subcutaneous tissue, in the muscles, towards the bone also, we completely remove that. We remove the necrotic tissue. Debridement of the necrotic tissue is done because most of the muscles and the tissues get necrosed because of the ischemia. Okay, because of the prolonged, for example, if the patient is coming late to the hospital. Exactly. So after that, you do irrigation. This irrigation means washing the wound with normal saline. Okay. So approximately, if there is a 1 to 10 centimeter wound, 3 to 6 liters of normal saline is used for washing the wound. This washing should be of high volume and low pressure. So there is one more that instrument comes that is called as a pulsatile lavage. Okay, that can also be used, not commonly used, but in common rural practices and in low setup cities, the wound can be washed with running water also. That is the best. Washing the wound with running water is the best, so that whatever impurities, like whatever contamination is there, it just washes away with the flow of the water. Okay, so operating within 6 to 8 hours. So once the debridement is done, once the irrigation is done, you clean the edges of the fracture site. You remove the hematoma also. Now, what do we do? Do we stabilize the fracture site, or do we just leave the fracture site like that? So in this stabilization, we do external fixation. So whenever there is an open fracture, we do external fixation. Whereas whenever there is a closed fracture, you can go directly with the intramedullary nailing. There was one question on that. if there is a tibia fracture is there, which one will we prefer, reaming or unreamed, if it is open or closed? Okay. So whenever there is an open fracture, we just directly go for external fixation. Okay. With this, what happens? The operative time is limited. The damage to the patient is limited. Also, we give time for the wound to heal. Okay. So if we are not directly putting any nail or any plate inside at the fracture site, because if we are doing that, we are introducing infection again, because any implant is just a foreign body inside the body. So what are external fixators? External fixators will just support the fracture from outside. Okay. It will just support the fracture from outside. And these are to be used in the patients where there is wound is there. You let the wound heal. You can keep the X-fix for 4 to 6 weeks, and once the wound is completely healed and there is no discharge at the site, you can remove the X-fix and you can do nailing also in tibia, as you said. So this time the nailing is to be done as reamed nailing is done, reaming is done. Okay, so most commonly these days reaming of the tibia is done, reamed nailing is done, but earlier now we are doing ream nailing because interlocking nails are used. Okay, earlier there was no reaming. Directly the nail used to be inserted because of the tight intermedullary canal. This nailing was called as V nail. Okay, now these days we do interlocking nailing. So most commonly we do reaming only, because we ream more than the size of the nail, more than the nail size. Okay,
Yes.
for a better stability we put a larger nail. Okay, yes. So yeah, what else? Any other questions?
Okay, okay, sir. I'll ask you some questions. What do you have? First,
Yes,
yeah, tibia fracture. You just told what will you prefer. Right? So, in case of closed fracture, what will you prefer, reaming or unreaming? In case of closed fracture,
reaming, reaming,
reaming.
because what happens is reaming, it provides you that osteogenic material, okay, that is required for the bone growth or the osteogenesis or the ossification that is required. So in closed, what do? You directly ream it. Once reaming is done, whatever the marrow material is there, this marrow has stem cells also. So this
Mm.
marrow has stem cells. This stem cells helps in the growth of the fracture site at the fracture site. Okay, so reaming is better than unreamed.
Okay. Next question: what you have in a mid-calf humerus fracture with the neuropraxia, and what
Yes,
is preferred? Nailing is preferred, or it is plating is preferred?
plating is preferred. In humerus shaft fracture, mostly plating is preferred. Okay, this is because I'll tell you, with a nerve injury, you are saying, okay, we do not exactly know if it is a neuropraxia or axonotmesis or a neurotemesis exactly. So what happens whenever there is you are suspecting neuropraxia, you're just suspecting neuropraxia, you cannot directly predict if it is neuropraxia, axonotmesis or neurotemesis. Okay, because this also takes some 3 to 6 weeks. So you cannot actually wait for 3 to 6 weeks for the fracture, for the neuropraxia to heal completely and then you go and operate the fracture.
Then,
No. So whenever there is a fracture, you immediately explore with some nerve injury you are suspecting. You immediately expose the fracture site, you remove the nerve from that particular site, and then you repair the fracture with plating and not with nailing. So plating is more preferred than nailing in this.
there was
Nailing is
a
done in
question.
yes,
Yes,
yes.
sir. Continue.
Nailing is done in old individuals, morely where the patient is more debilitated and you cannot take a larger incision and such things. You can do nailing,
That time.
but more commonly plating is preferred.
Then, sir, there is one question about that's compartment syndrome only. It's like which statement by a patient who just received the cast on the right arm for a fracture
Exactly.
requires to notify the patient immediately.
Yes. So whenever we put a cast for the patient, for example, if there is if we have put on above elbow cast for the patient, and we explain the patient regarding the complications, like if the patient is having any pain, distally patient को pain होगा fingers में, patient will be having difficulty in moving the fingers. There will be change in the color of the skin. Also, the patient will be having tingling numbness in whichever nerve is involved. Along that nerve route, the patient will be having tingling numbness will be there. So you explain the patient about these symptoms and immediately advise the patient to remove the cast at home itself, because it is not that difficult. Remove the cast at home itself, and then you can come to the hospital for further management. But do not just keep the cast like that. So these findings we tell the patient first whenever we are putting a cast.
I just add one more point. So actually, in this which statement by a patient they have put, it will be that the patient will not be basically patient will not will be taking more analgesic as required. So pain is the main symptom for compartment syndrome. Actually, what I have read.
Yeah, yeah, exactly. Pain will be more, obviously. That
Yeah.
pain will be
So
more.
yeah, that one. Okay, so next what we have is what's be the maximum time duration between an open fracture and surgery? Old already it's before 8 hours
Yes, I
only.
told it is. Yes, you if it is better if you operate within 6 to 8 hours, but maximum up to 24 hours you can operate that. It
Yes.
is okay if you operate till 24 hours.
And suppose there is a patient who has open fracture but is not contaminated. So what type of antibiotic you will give?
Yes, I'm sorry, I forgot to tell you this point. So whenever there is open fracture, when there is type 1, type 2, Castillo-Anderson type of fractures are there, you just give first generation cephalosporins in this patient. Okay, first generation cephalosporin antibiotics are to be administered. Okay. Also, if there is type 3 type of injuries, okay, in these injuries you administer one more aminoglycoside with this cephalosporins. So 2 drugs are to be given during that time. Okay. Also, eventually, as the wound gets contaminated and there are chances of infection, you take the culture from the site and then accordingly you can change the antibiotics also. According, but not initially. Initially, only these two,
So,
cephalosporins and amikacin. Yes.
and the last question, how will you decide whether to proceed with early debridement and delayed wound closure or immediate wound closure? Like will
This
be
depends
immediately
upon
or
how.
delayed?
Exactly. So this will depend upon the amount of the skin that is left, skin and the soft tissue that is left for closure over the fracture site. Okay. If the skin over the fracture site is lost completely, you do not have coverage at all, then there are two things that we can do. Either we can just close the wound with paraffin gauze dressing, and we do repeatedly dressing with just to avoid the infection. Keep the wound open itself. Do not try to close it at all. Okay, because if you try to put a suture again, you are inserting a foreign body at the site which is already infected. You can insert more infection there. So that is one thing. Another very good thing is vacuum assisted closure. That is called as a vac dressing. Okay, vac dressing, it comes like a sponge. Okay, with a tube and a suction machine. So this suction machine sucks all whatever unwanted fluid is there or whatever infected material is there. Okay, it sucks that, and also it promotes the granulation tissue formation at the wound site. So what happens whenever the skin loss is there or soft tissue loss is there? This vacuum dressing helps in growth of the granulation tissue at the site, and with this you can further go ahead with this can be kept for like 2 to 5 days, and after that you can go ahead with closure with skin grafting. Okay, either with skin grafting or just with secondary intention also it can close.
Yeah, we'll finish the session, sir. And sir, thank you so much for joining. Sir.
Thank you so much.
Yeah.